Thank you for inviting me to present this COVID-19 vaccination guidance on behalf of my co-authors and the Chartered Institute of Ergonomics and Human Factors. The guidance aims to support the safe rollout of COVID-19 vaccination programs by considering a number of work systems, such as manufacturing the vaccine, filling and packaging it for distribution, the testing and approval process, cold chain delivery, for example with the Pfizer and Moderna vaccine, and then the booking systems for the vaccination appointments, the local administration of the vaccine, and finally patient follow-up. We offer 10 principles to support systems thinking. To firstly identify and describe work systems, secondly to improve systems and processes, and thirdly to adapt and achieve sustainable change through continuous learning from experience. The delivery of national COVID-19 vaccination programs is on a scale that has never been seen before. It requires coordination between vaccine logistics, local administration centres and the population, and we know that populations are incredibly diverse and that people have different needs. So, for example, it's important to understand the needs of older people with respect to transportation and using the internet or mobile phones to book vaccination appointments. If we look more specifically at local vaccination centres, the primary functions are to plan the service delivery, manage appointments, vaccinate patients and monitor the service delivery. So we need to think about the people in each work system who will be interacting with other people, tools and equipment, a diverse range of tasks, their physical surroundings or environment, and the overall organisational structure and other external factors. We start with the identify stage, where we have set out 5 principles for human factors ergonomics issues. Just to note that I will use these 2 terms interchangeably throughout the presentation. Our first principle is to understand people's needs and capabilities. For patients, it is important to consider the wide range of abilities and needs relating, for example, to age, mobility, preferences, communication abilities, which could include reading and health literacy and other factors. For staff, the considerations need to include their well-being, including hydration and comfort breaks, especially if they're working long shifts. The design of workstations should consider different physical attributes, including the working envelope for reach distances, and should also be designed to protect the staff from safety risks, including aggression and violence. Delivering the vaccination programme will use lots of different tools and equipment. So we can start by thinking about the design of workplace desks, chairs and IT systems, and the use of ergonomic principles for anthropometry will be very helpful. Then we need to consider specific tools and equipment which are used to deliver the vaccine. This will include syringes, sharps, disposal containers and bins for used masks and other personal protective equipment. Task analysis is a core ergonomics method which can be used to think about what is the tool used for, who needs to use it, how easy is it to understand and use, how easily it can be disinfected and disposed. If design of the physical space is overlooked, we often see staff adopting workarounds to cope. As we know that well-designed physical spaces can improve efficiency and enhance experience, we feel this is particularly important for COVID-19, when we need to consider social distancing and ventilation. To start the patient journey, design considerations for arrival should include parking and accessibility. The signage needs to be well designed and in appropriate locations to support successful navigation through the one-way queuing systems. The waiting areas need to be planned to support social distancing. Additional space might be needed for different seating options, wheelchair users, mobility aids, and if the patient is accompanied to attend for vaccination. As I previously mentioned, if staff working in the vaccination areas are likely to be there for long periods, they should be able to adjust the chair or desk to fit them, and the lighting should be adequate for reading and using syringes. After the vaccination, there may be another waiting area to check for possible adverse reactions. This needs to be clearly signposted with information about the one-way exit route. As part of our ergonomics review, we look at what people are supposed to do, which we call work as imagined. This is usually derived from policies and procedures, and then we compare this with what people actually do. which we call work as done. To help us describe the tasks, we can break them down hierarchically to look at individual steps and potential process vulnerabilities. For example, this hierarchical task analysis shows in more detail the appointment bookings with 4 steps: to invite the patient in, book the patient in, manage any required changes to bookings, and manage scheduling across diverse settings, which might include care homes and different vaccination centres. So using the detailed task descriptions, we can then analyse the tasks systematically to identify potential vulnerabilities and risks. We want to think about how a task might fail and what the impact would be, how likely the failure is there anything in the system which makes the failure more or less likely, and what safeguards are there to protect against the consequences. Let's move on to the improve stage with 3 human factors principles. As we now understand the specifics of the work systems, we can start to think about improvements. These should always be developed with the people who are involved in the process, including both healthcare workers and patients. Examples of improvements could include redesigning equipment, changing task steps, developing more usable work instructions and further training, and redesigning aspects of the physical work environment. The Canadian Centre for Occupational Health and Safety has useful guidance on working in a standing position, if the task has been designed for vaccinators to stand for long periods of time. For any work task, we need instructions, and the Chartered Institute of Ergonomics and Human Factors has developed a separate guide to support the development of procedures. This includes useful tips, such as clearly marking high-risk task steps and giving a rationale to explain why the step is high risk, providing signs and displays which consider visual impairments, including from the use of masks, safety glasses and visors, and making sure that text used to write the procedures can be easily understood and is in plain language. The design and delivery of the training is important to ensure that both competence and confidence are achieved, especially as there will be people who are new to this area of work and are learning new tasks. As well as formal training, there needs to be supervision for on-the-job training. In this complex system, there may be a high turnover of staff, and with people wearing masks and safety visors, it will be useful to have clear name badges, including a role designation. This will help the quick identification of experienced staff who can provide support and guidance, especially in emergency situations or if something unexpected happens. One of the benefits of taking a human factors approach is that good user-centered design principles often reduce training requirements by improving the design of task and user interface. This can make the task more intuitive for the user, and hopefully there'll be fewer mistakes. Finally, the 3rd stage of adapt, with the final 2 principles. Where possible, we can build on previous experiences of systems for delivering vaccinations, for example polio and other childhood vaccination programs. However, the challenges presented by the COVID-19 vaccination program are different, for example with the need to maintain social distancing. So it is likely that processes and systems will need to be adapted dynamically. Staff often find good solutions to everyday challenges, and these can be documented so that lessons are not lost, and that processes can be adapted to achieve sustainable change. The Chartered Institute of Ergonomics and Human Factors has a separate guide on achieving sustainable change. There is a link to all our COVID-19 resources at the end of this presentation. This describes organisational learning in terms of the mindset, or the organisation's learning structure, and then in terms of the actions, or the learning process to implement it. The learning structure includes what the learning goals are, who is involved in organisational learning, and what kinds of situations are the focus of learning. The learning process describes how organisational learning actually takes place in an organisation or how it is carried out. Our guide emphasises learning from everyday work rather than just from incidents, in order to understand how staff adapt to situations and changes. It emphasises they should have an active role in organisational learning to ensure that the learning is related to practice in a meaningful way. We know that even the best systems can fail and potentially cause harm. There need to be mechanisms in place to identify incidents quickly and then to implement changes which reduce any unacceptable risks. Learning from incidents is a well-established approach and practiced in healthcare as well as in other industries. Some of the potential incidents for the COVID-19 vaccination systems might include the wrong vaccination documentation, dilution errors, wrong dosage, adverse reaction to vaccine, and delay to the second dose of the vaccine. I'd like to thank all the contributors for their roles in the development of this guidance, and especially to Carlos and his colleagues for translating it into Spanish. You can find more information about human factors ergonomics in COVID-19 at this website. Thanks for your interest and attention, and good luck with your vaccination programs.